ideas to discuss. Okay? All right. So we're going to talk about some Medicare developments, some regulatory developments that affect podiatry. These are really the three areas I was going to spend some time on. Some new Medicare reimbursement rules. This is the part of the program where Bob will join in if he wishes to. I want to talk about what's happening with some Medicare revocation and credentialing, things that are happening, and then just some enforcement action by the government, by CMS, and by the OCR, the Office for Civil Rights, which is the agency that enforces HIPAA. And I always like to make clear, my wife, some of you may remember, my wife was here last year and heard my presentation, and she said, "Kevin, I'm not even a podiatrist," and I was scared listening to that talk. And, you know, my goal here is not to scare anybody. It gives me no joy to say something that scares anybody. My goal is for people to be aware so that they can protect themselves, be prepared, change things they need to change, but that's my goal. And so if scaring you helps, fine, but that's not why I'm here. So just be aware, some of the things we'll talk about will sound a little bit scary, but that's not the purpose here. So let's talk about the new reimbursement rules. So every year, you may not be aware of it, but every year the federal government publishes something called the Medicare Physician Fee Schedule. It's published in a very lengthy document called the Federal Register, and it contains CMS's official policies for reimbursement for the coming year. So that came out towards the end of 2019. Parts of that are effective right now. Other parts are going to be effective in January 1st of 2021. The parts I'm really going to be talking about tonight are the parts that are going to come into play a year from now. And these will affect, everybody in the room because they are rules regarding evaluation and management services. All right? So let's talk about those. There's been extensive coordination between the CPT committee and CMS on these rules. For a while they weren't seeing eye to eye, but now apparently they are, and they've finalized these rules that will take effect a year from now. So on these rules, we know there were threats before that they were going to compress all of the E&M services into just one or two levels, right? Well, that was beaten back, and now they are going to eliminate 99201, but they are going to keep the other four levels for new patient visits. Okay? For established patient visits, they will still have all 5 levels. Okay? So instead of having 10 levels reduced to 3 or 4, there's still 9 left. But they have eliminated the 99201. Okay? And we all know that most of you are rarely going to be using 99211, right? Because you don't even have to be personally present. One of your assistants could use that code potentially. So I'm not even going to talk about that particular code. So the AMA CPT editorial panel and CPT have finalized these rules, and really the little quote there really sets forth their thought process. They say office visits will now be centered around how physicians think and take care of patients, and not on mandatory standards that encourage copy, paste, and checking boxes. Okay? So there still is some of that remaining, but a lot of it is going out the door. So before, a lot of the ways you established E&M levels was how many boxes you checked off in a particular category, right? That will not be true to the same extent going forward. Okay? So again, this is their thought process. So let's talk about this a little bit. Previously, to establish the level for E&M coding, there were three main criteria. You know, the history, the exam, and medical decision making. Now, I will say that in certain circumstances, you could also bill based on time for a particular visit if it was dominated by counseling. So right now, that's up until January 1st of the coming year, the criteria is history, exam, and medical decision making, or for a visit that's dominated by counseling, you can use time for that. Okay. Starting January 1st, there's only going to be two options, and those are going to be medical decision making or time. Okay. Those are going to be the two choices you have in establishing the level of an E&M visit. Okay? And again, it's also important to point out that these things apply to office and outpatient E&M coding. It does not apply to inpatient, ER, or nursing home. Okay? So we're talking about office visits and outpatient. These new rules that take effect January 1st of next year. Okay? Any confusion on that? All right. So we have our two criteria, medical decision making or time. Let's start and talk about time. Okay? The criteria here for using time is different than it was before. Before, it had to be a visit that was dominated by counseling. That is no longer going to be true. Okay? These do not have to be counseling visits going forward. What they will look at going forward will be the total time on the date of the encounter. Okay? And what will be included in the quote-unquote total time? It will be personal time spent by you, the doctor, or a qualified health professional, which could be a nurse or I believe a medical assistant in your office, potentially. And it includes both face-to-face time and non-face-to-face time, depending on the particular activity. Okay? So what we have is total time, and then we have various components that you can add in to make up the total time, which will include some face-to-face activities and other activities that happen while you're not in front of the patient. So there's a lot more flexibility in billing with time under the new rules than there was before. It was very narrow when you could use time before. Now it's going to be really much more open, where you could do it on every visit if you chose to. And for reasons Bob may talk about later, you may not choose to do this for certain reasons, okay? All right, so let's talk about some of these activities that are included in the quote-unquote total time. And some of these happen before you ever see the patient, such as, preparing to see the patient by reviewing tests or studies. Okay? You can now include that in the time that makes up the total time of the visit. Okay? Obtaining or reviewing a separately obtained history. Okay, so maybe your front desk person or your medical assistant obtained a history and you spent some time reviewing it. Okay, that could be included in this. All right, so those first two bullets are things that happen potentially before you ever walk in and see the patient, and they are included in the total visit time. Okay, the next couple things are going to be happening during the visit itself, performing the examination, and doing counseling and education with, you see the three choices, patient, family, or caregivers. Okay, that all can be included. Some of those things could potentially happen either during or after the visit itself. Okay, All right, continuing the list. These are things you can include in the total time of the visit. So, ordering medications. Many of these things are going to now, these next bullets are going to be happening after you've been face-to-face with the patient. So, ordering medications, tests, or procedures, communicating with other doctors, doing referrals, contacting them, doing your documentation or your dictation or entering it on the EMR, that's now included, okay? Interpreting results of tests and care coordination. So all of these activities that have now been listed here in the first set of bullets and now this set of bullets can all be included in the total time, okay? To me, there's an unusual amount of liberality here from CMS that sometimes we don't see all the time. So that's good. We're talking about total time. These are the total times for the various codes. You see the new patient visits, for example, 99202, which is now the lowest new patient code, 15 to 29 minutes, with those various activities in the bullets that we just went through. Okay, and you see them for the other new patient and established patient codes. Okay, all right. Couple caveats here. If you take a patient to have an x-ray done or have your assistant take the patient, that time in performing that study is not included in the total time. Okay, so that's important to know. Okay, now if, however, after you've done the study, you are reviewing and interpreting and analyzing that study, that does count in the total time. Okay. All right. Now, there's a new code for what is called prolonged services. So as you saw in these prior screens, the very highest code for a new patient goes to 74 minutes, right? The very highest code for an established patient goes up to 54 minutes. What happens if you go beyond those times? What do you do? Well, the answer is you use one of these prolonged service codes, okay? And I don't know if you can see that okay, but basically these go in 15-minute increments, okay? So if you basically say it's a new patient where you go 15 minutes past the 74, actually it'd be 75 plus 15, so now we're at 90 minutes. If you go 90 minutes, you would use the prolonged service code, and you would actually do 99205 X1. The X1 showing you went 15 minutes past the time. If you went 30 minutes past, it would be X2, and so on. 45 minutes, X3. I don't know how high the X's go up, but that's the system or methodology for these prolonged service codes. Okay? All right. Any questions so far? All right. Is this disseminated and people aware of these rules already? How many have heard about this already?
Not in detail.
Oh, okay. All right.
I have a question. I mean, maybe you're going to address this. So on this timing thing, going in, getting an x-ray, this and that, do we envision a stopwatch?
Yeah, great question. That's interesting because there are so many little components that could be timed, these different activities that you're doing before, during, and after the visit. My feeling is, you would want to record a beginning time and an end time for the activities of that day. And there's going to be probably some estimating and rounding off during that process. Bob, what do you think?
Well, I see a lot of confusion coming down the line. I think we've replaced one system with a terrible system now, because what happens when you have overlapping patients? How are you going to start focusing on that?
Exactly.
And so this particular system, I also have some real concerns, because I do a lot of criminal cases where we've had FBI agents up there talking about, this doctor could not have seen this many patients in one day. I did the math, and according to what I saw, he worked a 39-hour day this day. And I could just see all sorts of possibilities down there that I think they're really going to be creating a much larger mess. Now, the one thing I will say, 2 or 3 weeks ago, I was in Chicago at the AMA CPT meeting, and I sat through the dog and pony show there that CMS was putting on. It was disturbing, to say the least. And the one thing, though, that they kept pointing out is, now, this is where we are right now. Things are going to change over the next year. They're going to keep ratcheting this down. They're going to keep changing it around and everything. And one thing they mentioned on multiple occasions is, as Kevin's going to talk to the other different possibilities, but the one thing they did say is, and some of the doctors, if they decide they want to continue doing it the way we're doing it now, we will allow that as well.
Oh, really?
Yeah.
Wow.
So I'll talk further about that, but that came out in the meetings, and we had medical directors from CMS that was putting these presentations on. And we came out of there with more confusion and far less information than we went in with.
But to be clear, that's talk in a seminar, albeit from authoritative people. What we have on paper is a final rule in the Federal Register, which is what you're seeing on screen. Okay? So what you're seeing on screen could have tweaks happen, but as of today, that is the formal guidance in the Federal Register. Okay? So of course, during the course of the year, we are going to watch, and maybe if I'm standing here a year from now, I'll be saying, hey guys, remember what we talked about a year ago? Well, here have been some modifications. This isn't going to go away. I mean, there is going to be some version of this that remains, and maybe it's 90% of what we're doing today, maybe it's 100%, maybe it's 50%, but this is not going away. There is going to be some version of this coming. Okay, so Bob, I'm not sure you answered the question, which was, do you use a stopwatch, or do you estimate, or how do you propose they do that?
Well, having worked on a number of cases, I can tell you that anytime you're in any type of an audit or an investigation that's going on, you've got to have some great documentation. And quite frankly, I would be very concerned if you're not really documenting things and have some type of a formal documentation system. That's why I'm saying I think it's going to be more confusion, because, we're replacing one kind of a checkoff box with another one technically. But now you got to remember, okay, I was just here for 3 minutes. I'm over here for 5 minutes. I got to come back here for 4 minutes. And that's why I just see so much confusion. And how we're going to document that scares me.
Yeah, this reminds me a little bit of lawyers with billable hours.
Yeah.
I live day to day on billable hours, and I may work on 15 different clients' cases during the day. How do you keep track of that? Lawyers do different things, but I have a little notepad by my desk, and every time I go from one client to another, I just scratch a little notation. So through the day, I have these notations, and at the end of the day, I add them up. That's how I do it. So maybe this is going to be something like that. But did you have further comment, Eric?
So I was just, I was kind of envisioning having a little, button that you push as you walked into the room, boom, and you push it when you left the room, and I can see that.
I can see a software program coming out on your EMR where as you start with a patient, you hit the button, and as you finish, you hit the button, and it logs the time in for you.
Right.
I can see that happen. And maybe you say, okay, 5 minutes of that, we were out doing the x-ray, so we're going to detect that. You're going to have to make adjustments to it. But I can see this being automated and happening in a logical way. Okay, questions?
That was just my question. How are you going to document that? And you just write that in your note and say, I was in there for 20 minutes?
Yeah, I'm hoping your computer's going to be able to do that for you, but if it isn't, you're going to want to manually record it on your chart. Saw another question over here.
I
Yes?
don't know if we're getting ahead, you may address it, but what about office visits and procedures for a separate related situation, you know what I mean? Is that, I mean, right now, we use like a 25 modifier, what's
Right,
now?
so the procedure isn't part of this, that's not gonna be part of the total time, because that's the procedure code.
Okay.
And the office visit is the office visit. They're not changing, to my knowledge, the rules on the 25 modifier. So whether you can bill both the procedure and the visit at the same time, those rules are staying the same, as far as I know. Is that correct, Bob?
Yeah, the bigger concern is going to be, how do you make certain that your documentation is going to support your procedure? Because they have local coverage determinations out there, and if your documentation does not meet those requirements, you could end up getting denied on your procedure. So that's a big concern.
And that's, Bob and I have talked about this extensively with these new rules about E&M coding. They may be great to get you to the level of a particular code, but you will still have to satisfy medical necessity under the LCDs or other Medicare guidance. And, you know, so we need to keep in mind, you may do all the time stuff just right, start and stop time and all that, but you've still got to establish the medical necessity for the procedure, and that usually means following an LCD. Okay, so that is a concern here. All right, so again, to reiterate, under the new rules coming January 1st, 2 criteria: time, medical decision making. We talked about time, we're going to medical decision making now. This has a lot of carryover from past practice, okay? So again, we know that medical decision making has been composed of 3 elements primarily: the number and complexity of the problems you address during the encounter, the amount or complexity of data that you analyze during the encounter, and the risks or complications, potential for risk, complication, morbidity, all of that, okay? Those are the 3 fundamental elements of medical decision making. So if you're going to be establishing E&M level of service based on medical decision making, this once again will be the criteria as it has been to some degree in the past. There will be 4 levels of medical decision making under the new standards: straightforward, low, moderate, and high. And how you use the 3 elements to get into these different categories will be part of the analysis. So these are tables from the Medicare guidance. And you know, just to give an example, so say 99202 or 99212. The criteria for those 2 codes is going to be virtually identical. That's going to be in the straightforward category of medical decision making. You can establish the number of complexity of problems with 1 minimal, self-limited, or minor problem, okay? As far as amount or complexity of data, minimal or none, and risk of morbidity, risk, so forth, minimal risk. And basically, if you meet 2 of those 3 across the board there, you've established the criteria for that code, 99212, 99202. Okay? And so this table just continues on with the higher codes. Okay? So I think folks have the slides, you can see that. But it's somewhat similar really to the analysis of medical decision making that existed for E&M coding in the past. They've tweaked it to some extent, but it's you know, very similar.
Where can we get a better copy of that? Those are pretty small on the slide.
Oh, on the slide they're small?
They're really little. Where could we get like one that we could blow
Yeah,
up?
this came from some CMS guidance materials. So if you go to the CMS website, I believe you'll find it there. Bob, do you know another resource?
I provided you that. It's a portal that you can access that will provide information on this whole process. They're supposed to be updating it throughout the year, so Go out to their website under education and look for that E&M portal out there.
I think the 2020 or 2021 CPT book will have these same tables also. I mean, they have to. They have to have that in there.
Yeah, we've actually seen, when I was at that meeting, they showed us, still not out obviously, but 2021, what it's going to look like. So we've seen some real changes in the E&M as far as the verbiage and everything.
All right. So, APMA coding materials would likely have some of this in it. I don't know. There could be multiple places where you find it. Okay. So the most unnerving part of my presentation's over because I'm not a coder or a biller, even though I work with one about every day. But anyway, hopefully I've not made that too unclear. Okay, so now we're going to go into a more legalistic area where I'm a little more on my own ground. So this is what I'm calling Medicare revocation and credentialing actions against doctors. And Bob would tell you this, and I will tell you this, that in the past 5 to 10 years, we've seen a very frightening level of action by CMS and Medicare contractors to take away doctors' ability to even participate in the Medicare program, okay? And with many doctors who have Medicare as a substantial part of their practice, that is almost a career-threatening event when this happens. And we did not see much of this before 5 or 10 years ago, and now we are seeing it frequently. And it's happening in a harsh way. It's happening where the doctor gets very little due process to defend themselves. And again, it's concerning. And I bring it up again because I want people to know this can happen to anyone. Even we see good doctor practices where this happens. It's not just sloppy, careless folks. It can happen to any kind of practice. So we want to be aware that these things are going on. We want to protect ourselves, make sure it doesn't happen in our particular practice. So you see 4 different terms on the screen that I want to help you understand what they mean, why they're important. So deactivation, revocation, suspension, and then affiliation, new rules about affiliation. So let's talk about these, make sure we understand what they are. So deactivation, let's talk about that first. So in this situation, the doctor remains in good status with Medicare. They're a Medicare provider, but Medicare simply says, you know what? We flipped the switch on your billing privileges right now. We flipped it off temporarily here. And we've done it because you haven't complied probably with a credentialing issue. You haven't revalidated, you haven't gone to PCOS and revalidated your credentialing, or you haven't updated some information from us. Maybe you've changed your address and you haven't told us about it. Okay? So for these sort of what you may call clerical reasons, they're saying we're flipping the switch right now on you on your privileges. Okay? And we see that happen a lot, okay, with various doctors. Okay? Now, once the doctor goes in and fixes that on the system, they'll flip the switch back on, restore the billing privileges, but there may be a gap. So maybe while you're fussing with this, with Medicare, maybe there's a 2-week gap from when they first flipped the switch off to when they flipped it back on. If you submitted claims during that time period, you will not get paid on those claims. There will be what Medicare calls a billing gap. Okay? So that's why this can be painful. If it's just a few days, maybe not that painful, but we've seen doctors where it went on for weeks or months, and it was a major, cash flow problem for that practice. Okay? And again, it was large, in most situations, a clerical type error. Okay? Now, We know we have to periodically revalidate, right, on the PICO system. I don't know how often that is. Do you know how often? Is it every 6 years, Bob?
I don't know.
Okay. Is it 3? Okay, Terry's saying 3. So, does Medicare have an obligation to remind you when your 3-year time period is up? They say they will remind you, and sometimes they do remind you, but if they fail to remind you and you miss, do you have recourse? Probably not. Okay, so this is like message to office staff, know when our revalidation date is, and for heaven's sake, let us not miss it. Okay, let's be on top of it.
One thing I'd like to point out, some of the cases we've seen like this, the information has been sent to the provider, however, there's an inaccurate address out there. You need to make certain that you are always changing your addresses, you're keeping everything up to date, because if they send it to the wrong one and that mail is returned, they're going to go ahead and deactivate it. They're not going to worry about trying to help you out of the problem.
Or
so it's very, very important that stays current.
Or if you've given them an email address and you are no longer using that email address, they will be sending it to that email address and you may not know, and they may say, we did remind you, and you didn't get the email. We have lots of doctors tell us that. They give Medicare an email address and then they forget about it, and 2 years later, Medicare's still sending stuff to that email. The doctor never looks at the email, or they've changed it or whatever. So again, recognize if you're giving an email to Medicare, they're going to consider that as notice to you. And they may not give you notice, or they may give you notice in some of these situations. All right, that's deactivation, the least serious of the various things that can happen. All right, let's go to the next thing, which is revocation. Okay, revocation is a more serious matter, and again, CMS is very harsh with this, very aggressive, and again, doctors appear to have very harsh with this, very aggressive, and again, doctors appear to have very little due process. So what does revocation mean? Here, it actually means that your status as a Medicare provider is being essentially terminated, okay? This is not flipping the switch on or off. This is like, you cannot bill the Medicare system anymore. You're out, okay? And what are the grounds they can do that on? There are, I think, close to 10 to 15 different grounds they can do this on. I've listed on this slide and the next 9 of them, so let's read them. Non-compliance with Medicare enrollment requirements. Okay. Having a felony conviction. Okay. And this can be as far back as 10 years ago. Having a felony conviction. If they find that out, they can revoke a doctor's Medicare status. Okay. False or misleading information on your enrollment application. Okay. And again, this could potentially be unintentional, but something that you put there that was serious enough that it made your application be incorrect or false. Here's one that Bob and I have seen a lot of. On-site reviews that determine a provider or supplier is no longer operational. So what happens in these situations? Doctor has forgotten to tell Medicare that they've changed address. They've gone down the street 3 blocks now. Medicare sends an investigator to the old address and no one's there. Medicare says, oh, this doctor's no longer operational at their Medicare official address. Their status is revoked. Okay? So even something as simple as not correcting or updating your address with Medicare. Another thing we see is the issue of posting of hours. If you have official hours and you post them and you are not present during the hours that you post, or your staff is not present, doesn't have to be the doctor, but someone has to be there. If they show up at that office and they read Monday through Friday, 9 to 5, and they're standing there, you know, on Thursday afternoon at 3 o'clock and no one is there, they can revoke your Medicare status. That shocks people when I tell them that. We have had multiple doctors where that has happened to them. Okay, yes?
In terms of posting those hours, I mean, we post them on our website, those kind of things. There also needs to be a physical posting at your place of business, right?
Right.
Right there on the door.
And if you happen to be observing a holiday or something, do you need to put something on the door saying we're observing Christmas or we're observing New Year's and we'll be closed?
I think you would probably get away if you weren't there on Christmas Day and you wouldn't have to say that. But if you're taking a holiday that's not commonly observed, you know.
The good
like,
thing is they don't show up on Christmas either.
Yeah. You know, maybe you're doing the 24th of July in eastern Idaho. You know, we know everyone in Utah is closing on that date, but in Idaho, Medicare investigators are not going to know that, okay? So that might be an example where you would say something, okay? All right, is there another question? Yes.
If you post something on your door, then that would be sufficient. Like, our offices will be closed Thursday, Friday this week.
Right,
Then that counts.
correct.
Okay.
Okay, so these are rules on revocation. Okay, this is a serious thing because when you get revoked from the Medicare system, it doesn't stop there. It affects you in other places. You become a member of something called the preclusion list, which goes out to all the Medicaid organizations, and you will also be kicked out of Medicaid. In addition, you may also have some of your commercial health plans that may raise an issue with you and say, hey, we've seen you're out of the Medicare system. Why is that? They may raise an issue, but it's a very catastrophic event to be revoked in the Medicare system. Stuart, did you
Well, I
have-
just saw that Medicare or Medicaid termination, so it's vice versa.
It's vice versa. Yeah.
Also, the Medicare Advantage programs are on the preclusion list.
All of it.
Okay. Yeah. So Medicare Advantage would be infected also.
So when we're talking about, like, number 8, Medicaid termination, that's termination of a physician by Medicaid, not necessarily a physician opting out of Medicaid.
Yeah, it's
right?
termination for cause, essentially. Yeah, if you just decide, hey, I'm not going to see Medicaid anymore, that's not going to be one of these grounds. Okay. All right. We've done deactivation. We've done revocation. Third one is suspension. This is an odd duck situation. This is a situation where the government is not taking any action against your status as a Medicare provider. But what they are doing is saying, okay, we're going to take claims from you, we're going to adjudicate them, but we're going to put that money essentially in limbo, in escrow, and we're just going to hold it. Okay? Now, why does Medicare do that? Well, there's a few reasons. One, the statutory reason is if they find that there is quote-unquote credible evidence of fraud in your billing practices, they can suspend your payments until they've done investigation, okay? Often we see this in a situation where a large audit is going on and Medicare's looking down the road saying, we think we've got a big overpayment that we're going to be trying to claw back from the doctor. And we want a little fund there to, collect against. So they start holding money in that fund, and then when they determine their big overpayment, they go against that fund and take that money so they don't have to chase the doctor. So that's why Medicare does suspensions. Bob and I right now are handling multiple suspensions around the country, okay? And again, we have a doctor right now who's about to go bankrupt. He's in Michigan. They went to his office. They said, You know, we don't think, you say you're doing avulsions, we don't believe you're doing avulsions. They supposedly went and interviewed his patients. The patient said, oh yeah, the doctor wasn't doing surgery on me. He was just doing some little thing on my toenail. Okay, that's what the investigators supposedly say. So they suspended the doctor. He's getting no cash flow. He has a 100%, or pretty much 90% Medicare practice. And it's destroying his practice financially. Okay? The good news in that situation is we went out and interviewed those patients, and we have found out that, number one, the government never went and interviewed them, and number two, they affirmed that the doctor did in fact do avulsions. So we're fighting to try and get the suspensions overturned and fighting a very uphill battle in doing it. But that's a scenario where that's happening. And what we've come to find out is this phrase, credible evidence, means whatever the government wants it to mean. Unfortunately, that's the bottom line. And they're very stubborn about changing their mind, even when we show them that their whole investigation is false, as we are doing with this Michigan doctor. All right. Some real life examples. We've really already talked about several of these already. Bob and I are dealing with the situation in Georgia where it was a 3-doctor practice. One of the doctors committed Medicare fraud, was convicted in federal court, and was actually gone to jail. His partners, the moment they found out about it, said, okay, you're gone, you're out of our practice. Medicare came into them and said, okay, you've got one of your partners who's been convicted of a felony, and so we're revoking the entire practice. Okay? And Medicare, basically they're making various arguments, but they're saying, we don't think you severed your relationship with him quickly enough for our standards. Okay? So they're saying you didn't do it quick enough, and there's some litigation between the doctors because the remaining 2 partners are saying, we're not going to pay you, Mr. Expelled Doctor, we're not going to pay you for your partnership interest because you defrauded the practice. A legitimate argument. The doctor is saying, yes, you should pay me. So they're in litigation, and Medicare is saying, you know, you guys haven't completely severed your relationship because you're litigating with that doctor. So you're revoked. So we're fighting that through the appeals system right now. Horribly unfair, because the remaining 2 doctors did everything they could. They got rid of the guy. They terminated their relationship as best they could within their power. But they are being punished for what this guy did, and which they had no knowledge he was doing. Horrible, horrible outcome. Okay. Bob, any other situations with any of these deactivation, revocation, suspension that you think you would mention?
Yeah, I think the one thing we really need to talk about also is billing impropriety. We have had a number of podiatrists, most of them have been going into nursing homes, etc., that have, through no fault of their own, they have billed for deceased patients. And that's part of this particular section of the law out there that it's in the Code of Federal Regulation. And basically it's a strict liability statute. What we mean by that is that the only thing the government has to do is show that the doctor billed for a deceased patient. Now, we've been involved on probably 10 or 15 of these, and we're out there bringing in, for instance, the nursing home director. The director of nursing comes in and said, doctor was not at fault. What happened on this one particular case is we have a patient named Mary Jones. She's in room 402. When the doctor shows up to see the patients, he's given 60 face sheets. There's Mary Jones, room 402. He also has a medical assistant from the nursing home working with him. He walks into the room and says to the assistant, is this Mary Jones? Yes, it is. Goes to the patient, are you Mary Jones? Yes, I am. He performs the service, bills Medicare. Well, they gave him a face sheet for a patient who died 3 years earlier. Now, Medicare did not pay the service, they immediately denied it. He immediately billed it correctly, got paid. And we see this happening over and over in the nursing homes, different things like this. Now, it's not only deceased patients, but say for instance, if you have a billing person, and maybe they transpose a date, and there's a billing date out there that's used on a date when you were out of the country. Well, again, not any fault of yours, you had a billing person that made an innocent mistake. However, strict liability statute, they said, doctor, you bill for services that you could not have been performing because you were out of the country at this point in time. So the revocations, this is one of the big things that we've been battling over and over again. And the frustration of it is when we get in front of an administrative law judge, we have witnesses, exactly what happened. And finally the judge just looks at you and says, well, you know, I'm sorry folks, but there's nothing I can do because this is a strict liability statute. The only thing the government has to do is show that you built it. That's it.
And
So
the autofill function on computers is a big part of this too, because you start typing in the name Mary Jones and it will bring in another Mary Jones. And unless you're carefully checking a social security number or something like that, you'll miss it because of that autofill thing that's happening. Okay, moving on quickly. There is a proposed, the rules I've been talking about before are in place legally and have been for years. This is a proposed rule that is scary. And this rule says that doctors who are enrolling in the Medicare system or who are revalidating their enrollment must disclose any quote-unquote affiliation in the past 5 years with another doctor who falls in one of these 4 categories. That doctor has an uncollected debt to Medicare. They have been suspended in the past. They are excluded from the Medicare and Medicaid program, or they have had a revocation, denial, or termination from the Medicare program. Okay? And what does affiliation mean? It means one of these things. They have a 5% ownership in a practice. So if you are with another doctor who owns at least 5% of the practice with you, you are affiliated with that doctor. If you are in partnership with that doctor, you are affiliated. If you are a director or officer, or that doctor is a director or officer of your entity, you're affiliated with them. If they exercise any operational control in your practice, you are affiliated. Or if you assign any Medicare benefits to them, you are affiliated with them. So affiliation is important because it triggers these obligations to disclose these, prior bad things that have happened. And by disclosing that, you may now in fact be jeopardizing your own participation in the system. And here's the consequence. Failure to disclose one of the above affiliations on the doctor's enrollment and revalidation may result in denial or revocation of the enrollment or revalidation. Yes?
Can you explain what a reassignment relationship is, like some examples of that?
Bob can correct me. My understanding is you basically said that your right to receive payment is being assigned or transferred to another provider.
Well, what it means is you come to work for a group practice. You have to reassign your benefits to that practice. So the services you perform are billed under the group number that you reassign to, and that's where the payments will go.
So they're saying
you're reassigning to them.
And they're considering that an affiliation.
And that's a very common affiliation. But, the thing that I'm amazed by as I'm watching this, it sounds to me like now you have to go through and have a complete background check done on everybody you're going to, have in there as a partner or a associate in your practice.
Bob just anticipated the next slide. Before you hire someone, before you purchase a practice, before you become a partner with anyone, you have to do diligence. And that, yes, may involve a background check of some kind. And at a minimum, to sit down and talk with them and look, do you have a Medicare overpayment out there that you haven't paid? Have you ever been suspended from the Medicare system? You got to go through some of these questions. Stuart?
So that last slide said on revalidation. So if something happens before you reevaluate and you didn't disclose it, you're not held against that?
No, it would be the opposite. If it happened before you revalidated,
You have to report it.
you would have to report it at that next revalidation.
Okay.
All right, so there's, okay, yes, question.
So probably CMS is okay then if I was thinking of going to practice with Jason DeVries, if I called them and asked for info on Jason DeVries, would they tell me that he had some debt with them or there's an overpayment?
If you inquired of Medicare, you're saying?
Yeah.
Well, that's the problem here.
I'm just saying, to do my due diligence, I could ask Jason if he has a looming overpayment coming, and he could give me his word, but if I really wanted to look into it, can I get that info calling them?
Probably not.
No database at all?
Yeah, no database. Now, there is a database for people who have been excluded from the Medicare program, but there's not one for people who have just been suspended or revoked. There's not one for people who have Medicare debt owing. So, yeah, you've hit on a very good point. Our ability to do that due diligence is compromised, right? Okay. All right. This is my third area, and we're nearing the end of my time, and I don't want to take away from the ability to question Bob, but bear with me for maybe 5 to 7 minutes on this last area. So, fraud and abuse enforcement, OCR enforcement of HIPAA, what are we seeing around the country? We've seen some kickback things that Medicare's gone after involving podiatrists. A big one involving a compounding pharmacy, which went out to podiatrists and said, hey, we'd like to hire you to be a medical director and medical researcher for our pharmacy, and we'll pay you $40,000 a year. If you'll do some research for us and you'll track your patients who are using our creams and blah, 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 blah. We'll pay you $40,000 a year for it. And this isn't stated, but it's always implied. And by the way, we'd really like it if you prescribe our compounded medications, which are incredibly expensive, right? So that implied little thing is what the government is viewing as a kickback. And they're saying this $40,000 medical director fee is a sham, and what it really is a way to get the doctor to start prescribing their creams. We've had people go to jail in these schemes. Bob and I have represented several podiatrists and had situations, and you see some of them on screen. Doctor in Kentucky just paid $65,000. Doctor we're representing in North Carolina just paid $30,000. This is happening out there, so beware if they approach you with these very sweet sounding deals. They may be too good to be true, okay? Avulsions, for some reason, that's a big thing with Medicare right now, and they just see a fraudulent avulsion under every bush. You know, we have so many doctors being investigated for avulsions, and those doctors would be fine if they would just do basically 2 or 3 things. Number one, document that they've taken the nail all the way back to the eponychium. Number 2, document that they either used an anesthetic or why they didn't. Okay? If they would just do those 2 things, they would completely clear these investigations. But most of them are not documenting that, and unfortunately many of them are just whacking off a little corner of the nail and calling that an avulsion. Okay, we've had doctors go to jail over this seemingly minor issue. Okay, so if you're doing avulsions, please document those 2 things. Okay, don't put yourself up for these problems. I'm not going to talk about this silly case. Okay. HIPAA. What are we seeing in HIPAA? We're seeing doctors getting in trouble because they get a negative review on social media and they fight back. And when they fight back, they disclose protected information, and HIPAA says, can't do that. Very unfair, right, that you can't fight back, but they're starting to go after doctors who have done that, okay? Failing to grant access to patients to their medical records and their medical information. We've had 2 settlements, both for the same amount, $85,000, for practices who refused to do that or failed to do that properly, okay? The second one, the pain management practice, is interesting because the government dinged the practice for 3 things. First of all, they said, you know, you didn't provide the records to the third party that the patient asked you to. Number 2, when you did, you charged too much for the records. Number 3, patient said to do an electronic form and you did it in paper. So, settlement of $85,000 for those violations, okay? We had a large New York medical center pay a penalty of $3 million to the OCR. Why? Because they had multiple devices full of patient information that were not encrypted. And in today's day and age, if you have mobile devices like laptops, iPads, cell phones, if you have those devices with patient information on them and they are not encrypted, you're in huge trouble, okay? So if you have those devices, get your IT person and get them encrypted. And by the way, a password is not encryption, okay? Encryption is something far more, powerful than just the password. All right. You can just see some of these other things that have happened. Ransomware, hopefully no one in this room has had that happen, but we have doctors right now, we're defending, who've had ransomware attacks. And that means that the hacker comes in, it encrypts every bit of data on your computer system, locks it up, and you can't get it until you pay the ransom, okay? How do you combat that? The best thing is to have a good backup, and preferably one that they cannot hack as well, okay? Because there's been one situation where they not only hacked the system, they hacked the backup. So you want to have a freestanding, independent backup, hopefully on the cloud or on some kind of portable device, okay? All right, I've gone just a little bit over my time. We have about the next 20-25 minutes. Mr. Weatherford's in the house. He can answer coding questions that may be bothering you right now. So,
Not only coding questions, but just
Any questions.
things in general that are going on. Just to start off, some of the things that we haven't discussed yet. One of the things going on nationwide now is we're having RAC audits, recovery audit contractors. These are the lovely auditors that do it for commission. They get paid for this. And, the concerns that we've had about this, Kevin and I, is, okay, whenever we see these RAC auditors come in, we're used to reading about the RAC audits where they're done in hospitals. Now, hospitals, you can imagine, RAC auditor comes in, $1 million, $5 million, $10 million, they get a percentage of that. That's their bread and butter, that's where they want to be. But now all of a sudden we're finding in podiatry, particularly durable medical equipment mostly, that we have RAC auditors coming out and they're only requesting a small handful of records from the doctors. And we were seeing 3 and 4 records being requested. Most of the time it was DME, sometimes it has been routine foot care type codes. And as I'm looking at this, I'm thinking, why would a RAC auditor go after that little small percentage on the DME or on some nail debridements? It makes no sense. One of the things in their letters, when they send out a letter to you, they'll say, we would like to have these 4 records, or sometimes they've already, they assess an overpayment against you. And the way they're able to do this is without reviewing the medical record. It's called a desk audit. Sometimes they can look at billing and they can say, oh, wait a minute, I can see here, for instance, that this particular provider billed a specific code set that should not have been billed together. Could be considered a correct coding initiative violation. Or it could be that we have a CPT code that does not match up with the place of service code. So we're seeing all of these types of small audits come in, but right there in the letter, they say, now, if you don't agree with this, why don't you go ahead and we will give you a conference call. We'll be certain to talk with you and we'll explain this and you tell us why we're wrong. Well, that's a trap, folks, because if you go back to the Affordable Care Act that came out a number of years ago, one of the things that's required in there is if you know you have received money you're not entitled to, that you received money that you should not have been given, you have 60 days to refund that money, self-report it to the government and send that money back. So the concern that we have is if you get on the phone with them and you start talking and say, oh, I didn't realize that. I see. Okay, you're right. Yeah, I billed that incorrectly. Okay, I'm going to go ahead and I'm going to pay you back the $320 you're requesting. Now, my concern is what happens when they come back to you a year from now and say, by the way, you have refunded money. We have you on tape here where you called in. And did you self-report, go back 6 years? Because you were doing this for 6 years. Did you go back and did you refund that money to the government? So call me and I'm going to change my bio around because I was listening to it, I was reading it up here and said, there's nothing about the fact that I'm a government cynic, okay? Everything that I see out there, you know, when we were talking earlier about the documentation. Well, as I sat there in Chicago and I listened to all these Medicare medical directors saying, doctors, we were doing something good for you. We listen, we hear what you're saying, now we're here to help you out. I don't buy that, I'm sorry, because I can see things such as if you don't have good documentation, number one, you cannot support those procedures. Number two, if you want to get paid for an E&M service, you have to be able to show that you have a significant, separately identifiable service. How are you going to do that if you're just sitting there worrying about time? Or if you're only looking at medical necessity, you're not talking about, for instance, what about failed conservative measures? You know, these are things that get you your payments on your procedures.
Okay.
Medicare's not talking about that, but.
All right. Does anyone have a specific CPT coding question? Is there a code you're uncertain about usage on? Yes, Terry.
I have kind of a general question that's driving me crazy, which is Medicare Advantage related.
Mm-hmm.
We can't use ADNs.
Cannot use what?
ADNs for Medicare Advantage,
Mm-hmm.
anything. But how do we, like for durable medical equipment, like orthotics or a splint or something that is not covered under Medicare guidelines, but normally you can use an ABN where you tell a patient, this, we feel very strongly this will not be covered. You can make your decision. You want it, you want it billed, you want it, you don't want it billed, you don't want it. But we can't do that with Medicare Advantage. And they're telling us we have to send in a kind of a pre-auth, but then they can take 14 days to come back and give you an answer. And I don't know, it's kind of a mess. Is there a way to figure out?
Well, probably the only thing, I do have a background. I did in my old times, my dark ages, I ran an HMO, I set one up, and like, wow, I'm in the wrong place here. But you know, they have so many rules and regulations about not allowing you to bill the patients and do different things like that. And the one thing that we always tell all of our doctors is, you know, to me, when we talk about DME, okay, we have some LCDs out there, and you know, we tell the doctors all the time,
use your LCD guidelines for all of your patients, okay? Whether it's a Medicare Advantage plan, whether it's a commercial carrier, because that's the gold standard documentation. And what I'm trying to say is, if you can give them a really good medical record, you stand a good chance of getting payment up front. Secondly, on appeal, you stand much more likely a chance that you will get paid on that. But, you know, as far as being able to do anything else, they have that in every one of their policies. You cannot get the money from them up front. And, you know, the one thing that you don't want to do is bill for a coverage service that you said, well, I don't think this is covered. Well, maybe, and I see this a lot that happens out there, that service may be a covered service by Medicare, and a doctor does not realize it is. They can get themselves into trouble doing it that way. So you really just have to focus on medical necessity, learning those policies, and apply them to all of your carriers. And, you know, go through the appeal process and try to win at the appeal process.
Yeah, one of the problems with Medicare Advantage plans is they'll say, we have to follow Medicare guidelines, but we can do more. And so that little caveat opens up a whole can of worms where, well, does that mean this code that isn't covered by Medicare might now be covered because they can do more? It's been really frustrating.
And you have to look at their list of covered items. I mean,
Yeah.
And, yeah, amazing.
because some of them do cover more than Medicare.
And you know, when you look at an Advantage plan, I mean,
There's no advantage.
yeah. I'm sitting there looking at it, and you know, there are certain, for instance, drugs, you know, they have a drug plan built in on some of them. There are certain things that they will allow you, some dental coverage and different things like that, but you know, when it really comes down to an individual podiatric service, I don't think you're ever going to see them allowing anything other than what Medicare allows personally.
Yeah, they're, anyway.
Corey?
Yeah, this is another question that we've been running into. It's on the like and similar. So if we have a patient that comes in and maybe a different doctor's prescribed an over-the-counter lace-up ankle brace, and they come in with severe deformity and they need a more rigid structure like an Arizona brace, something like that, we're basically getting told, well, if they've had an L code before, every other L code is like it.
Yep.
And how do you get around that? Even if the product is not similar, or maybe not even for the same use.
Yeah, we're running into that across the nation. Makes no sense whatsoever. And what you've got to do is, I mean, first off, I would do everything in the world with that patient, making certain that you ask them all the questions. And I would almost think about developing a form where you're asking the patient to fill out a form talking about the fact that they have not received this, that, and the other, you know, give a signature from it. But secondly, if something is totally different, you know, you have to go through the appeal process, and you have to be able to show that it's very different. And, you know, what the patient got before obviously is not something that's going to help in this particular instance.
Yeah.
So we'll use that portal, that Medicare portal to check the code. And the only thing similar is it starts with an L, right? Like it's not even the same product. And we've appealed, and in the last year, we haven't won a single appeal.
Are you just going one level of appeal? Because you
Um,
may have to go to the ALJ
we have
level.
a couple starting in a second, but
Yeah.
Okay.
yeah.
Many of you have heard of Paul Kesselman. He's kind of a national guru on DME. He wrote a very good article for Podiatry Today where he talked about this very issue of like and similar and how to avoid it, how to appeal it, all that. I find that article is a really good article.
You know, one of the things that bothers me about it is I had to use a cam walker about 3 years ago after some surgery. Well, I didn't keep the cam walker. And, you know, all of a sudden if I go to see a doctor again and even if I need another cam walker, you know, it's not fair that that doctor is going to have to absorb the cost of that. And so, you know, to me, I just think there's a real overreach there on what they're doing, and that's why I think you have to go through the appeals. But again, I would really, you know, if you have some type of a form that you can work up where that patient is answering the questions, so you're showing, because ultimately you're going to get in front of a trier of fact on an appeal, and if you can show you did everything from a reasonability standpoint, you have a much better chance of prevailing on that.
Okay, other specific coding questions that are bugging people out there? Okay, be thinking of it. I'm going to play moderator here. So, Bob, you and I see hundreds of doctors. What are the most common coding and billing misunderstandings we see? Almost every office. What do we see?
At-risk routine foot care, okay? And we see so many times, this week, we were in a practice, and, you know, we find, here's a doctor that's not billing for corns and calluses. And there's a lot of money that you're leaving on the table if you do not understand at-risk routine foot care. So, you know, you want to make certain that you understand that, first off, at-risk routine foot care, you have to have a systemic disease, and you have to show the severity of the peripheral involvement. The way you do this through your documentation is you're documenting the class findings. We're talking about the DP pulse, the PT pulses, your advanced trophic changes, Class C. We're also talking about, you know, non-traumatic amputations. But you've got to document this in your record. And what we're telling every doctor, when Kevin and I go out and meet with a doctor, you know, I see so many times where the doctors do not understand that you do not, for 11720 and 11721, the debridement, you can do that under the at-risk routine foot care guidelines. If you meet the class findings, you have a systemic disease, and if it's one of the diseases with an asterisk, such as diabetes, peripheral neuropathy, etc., you have to show the MD or DO that's managing that. You have to be able to show the approximate date of the last visit, and you're providing Medicare with that information. And that last visit has to be within 180 days. Okay, so you're showing that this severity is so much so that it requires the active care of that MD or DO. Okay, and anytime, the good thing about using the at-risk routine foot care coverage guidelines is, number one, that means that all 10 of those nails meet the coverage criteria. So you don't have to go in there and describe each individual nail, and the nails do not have to be mycotic. How many of you think those nails, for 11720 and 11721, how many of you think the nails have to be mycotic to get paid?
It's kind of what we've been.
Yeah. That's one of the other ways you can get it. You can get paid for 11720 and 11721 if you have a patient that has onychomycosis and the nails are painful. And, you know, if only 4 of the nails are painful and you debride all 10, well, only 4 of them meet the coverage criteria, so you can only bill the 11720. But the other reason that we try to tell you to go in to use the at-risk routine foot care coverage guidelines is then you also are establishing coverage for corns and calluses. And those corns and calluses, you can do them every 61 days. What you have to do is you don't have to describe the corns and calluses, you have to show where they're located, okay? If they're around those nails, you can go ahead and do it, but you're not going to get to bill it, okay? But keep in mind, let's say if you had 2 corns up under 2 of the nails, if you've debrided 10 nails, you still get to bill 11721 because 8 of the nails did not have corns or calluses.
So the single most audited codes in podiatry are 11720 and 21. And the single greatest area of confusion by both Medicare and podiatrists are how you bill those codes, okay? And the biggest confusion is there's 2 sets of coverage standards: mycotic nails, routine foot care. And everyone wants to mix the 2 together. They're talking about systemic conditions and onychomycosis in the same breath. That's apples and oranges. We cannot do that. You know, they're billing a diagnosis of pain when they're doing the routine foot care guidelines. Those 2 don't go together, okay? So I think we've had this conversation in almost every office in the country we've been in. Keep those 2 sets of rules. It's the same CPT code, but there's 2 different ways you get to coverage. And you have to keep those 2 different ways separate and distinguished from each other. And if you don't, you'll get mixed up. And the problem is the Medicare people are already mixed up about it too, so they don't understand it either. And they start denying your payment because they don't understand. But you set yourself up for a denial when you're talking about a systemic condition and class findings, and then you tell them there's pain and onychomycosis. You've totally confused everybody now when you do that. So keep the two separate.
And you also confuse Medicare's computer. Anytime if you put in your systemic disease and your Q modifiers, and then you go in there and you put in the onychomycosis diagnosis code, well, if you put that code in there, you had better be putting in codes for pain of those nails, because you will get denied. And you know, many times I have doctors calling our office and they said, well, that doesn't work, Bob, it doesn't work. And we ask them, say, send us your medical records, send us your billing, and 9 times out of 10, it's that exact reason. I can always find onychomycosis on every one. And if you look, for instance, we have forms where we design forms that we use on at-risk routine foot care. We don't even give you the ability to describe the individual toenails because it's not necessary. All we're documenting is class findings, because the class findings are going to establish the coverage criteria. Now, if you have a patient with onychomycosis, that's when you have to get in there and you have to describe each individual nail, and you have to show which nails were painful or causing marked limitation of ambulation. And you also got to have a good description of your debridement procedure.
Question here.
Yes.
So then with routine, the at-risk, you don't need there's no need for any nail code, ICD-10 code. You don't need any of that.
Now, the only thing you really need is the systemic disease.
Okay.
Because that's what establishes the coverage criteria, the systemic disease.
And the class findings.
And the class findings, which are denoted by the Q7, Q8, or Q9 modifiers.
Yeah, learn how to use those Q modifiers correctly, and man, it will save you so much headache. And again, if you qualify for the nail debridement, you also qualify for the corns and calluses at the same time. You've established coverage at one time for all of that together.
So you're saying that when you're at risk, you don't have to describe the way you debrided the nail?
Yeah. Anytime you're debriding the nails, the procedure itself, what you need to do, you need to make certain you have a good description. I can show you, or I can send you a really good description.
I think we
for
have
debridement.
yours. Yeah.
And the other thing that you, you have to do that on both of those. Make certain that you also document the instruments that you're using. Kind of silly, that's some of the things that in the LCDs out there. We see denials all the time because they're saying, well, the doctors did not describe the instruments that he used to debride the nails.
There were some other questions.
Yes.
If you do both the nails and the corns and calluses, what modifier are you using for those two?
Okay, you're going to put the Q7, Q8, or Q9 modifiers on both of the codes, and then on the nails, and this is only with the 11720 and 11721, you're going to put a 59 modifier as well because of correct coding initiative. If you don't put that 59, your nails will be denied.
So the 5.9 goes on the nails, not the
Right,
callus.
on the nails.
Okay, question in the back.
Isn't it going to be an 11719 instead of 11720 or 21 if the nail's not mycotic, if it's not dystrophic?
No, if you're doing the at-risk routine foot care, the nail does not have to be mycotic. If you go in and, a lot of times when we walk into a doctor's office and we start having this, we've actually had Medicare tells us, well, Mr. Weatherford, you need to read your code. No, I have the code memorized. It doesn't say anywhere in a 720 or 721 that it's a mycotic nail. It says debridement by any method. Okay, so if you're taking care of it, say at-risk routine foot care, you meet the class finding, you debride the nails, use either 11720 or 11721. The 11719, which is the trimming of the non-dystrophic nail, GL127's trimming of a dystrophic nail. Kevin and I both say to the doctors, we don't really believe we should ever see you using this, because quite frankly, I rarely find a doctor that's just trimming nails. You know, trimming is the first step of the debridement process. And most of the doctors say, yeah, and we actually see a lot of doctors billing 11719, and as we review the record, they're showing us that they've debrided the nail. And when we ask them why they're doing this, they say, well, we're trying to stay below the radar. If we bill 11720 or 11721 too much, we're gonna get audited. No, make certain you're billing the correct code. Okay, we got a bunch of them now.
Okay, we got 5 minutes.
I just know last year, we were in this very same meeting, and Jeffrey Lerman said to start using those.
Start using what?
11719.
Yeah,
He said
exactly.
not the trimming of the nails. And
He made a specific point of never using the word debridement, and never of nails or a wound. He said use the word debulking of nails, specifically in pairing of corns and calluses. And so last year's meeting is totally different than what we're hearing this year.
Yeah, we have never one time, and Kevin and I have done over 1,000 cases with podiatrists, okay? And we have never had Medicare ever have an issue with the word debridement on anything. Now, where there is always an issue, and you know, I've had a lot of people from Medicare, and again, they don't understand this. Medicare people will say to you, well, you're using the code too much. Well, no, if you document it correctly, there is absolutely nothing they can do about that, because you document the record correctly. And we go through the audits all the time, and I can tell you, going through 11720s and 11721, when we get in front of an administrative law judge and we have a record that's documented appropriately, we're not gonna lose that case.
So, Jeff Lerman's a very sharp guy. He doesn't do Medicare audits, at least to the extent we do. We see debridement records getting approved every day by the government using the terminology we're telling you about, okay? You can do what he's saying to you, and it may work perfectly well too. You know, you can call it debulking if you want to instead of debridement, but debridement gets paid every day in America, thousands of times, and it passes audit thousands of times. As long as you've documented your record appropriately to support the debridement. So, I beg to differ.
And the very verbiage in the CPT code is
Debridement.
Debridement.
Yeah. So why would someone tell you not to use the term that's in the CPT book? I don't get it.
He
I
was
really
a
don't get it.
professional last year that he told us that word for word.
I believe you. And I know Jeff, and I know he's very smart, and I respect him. But,
it's good to know.
you know,
The calluses was the one that specifically says in the CPT that it's trimming or pairing of the callus. It doesn't say debridement, but for the nails, debridement is there.
yeah, the calluses, it's
Pairing and
pairing,
cutting.
Trimming of the
Pairing,
cutting,
cutting,
trimming, yeah,
cutting,
that's
callus.
correct.
Yes, sir.
So I was always under the impression that debridement implied that you were debulking the nail. So how do you build that if the nail isn't thick? And do
Well,
we have to document?
Yeah, doesn't have to be. Matter of fact, you know, Medicare is very liberal on talking about what makes, you know, as far as onychomycosis is concerned. You know, I've seen the term friable, I've seen, let's see, how many different ones we have? Crumbling, we have discolored, we have yellow, sometimes thickened. I mean, there are a whole variety of terms they will use to describe
He's
it.
talking about the mechanical act of debridement. So trimming is simply reducing length of the nail. Debridement is that plus doing something else to the nail, reducing girth, potentially debulking, removing subungual debris, potentially.
Yep.
It's doing something further beyond just reducing the length of the nail.
So if all we're doing is reducing the length, then we should be using the 11719.
I would
Yeah.
agree with that, yes,
Yeah.
yes.
And we rarely see, most of the time doctors say, no, I don't usually do that. But, you know, if you have onychomycosis, or again, with at-risk routine foot care, what you're trying to do is prevent this patient from becoming an amputee, so you're giving him scrupulous care.
All right, we're out of time. Bob's gonna be in the area for the next day or two. welcome to come up and ask him questions. Bob's a great resource. I really appreciate him being willing to come up to Sun Valley and join us, so thanks for
I had a choice of Sun Valley or Detroit, okay?